Hello, and welcome to Chagpar MD. I'm Dr. Anise Chagpar, and this week I have a very special guest, Dr. Jay Harness. Jay is not only a nationally renowned breast cancer surgeon, he's also one of the former presidents of the American Society of Breast Surgeons. And we are here to talk about oncoplastic surgery. Now, you might have heard the term, but what does it actually involve? Well, let's ask an expert. What do you say? Let's get started. Hi, Jay. Thank you so much for joining me today.
Hey, Anise, it's just fabulous to be with you. Thank you for inviting me.
So, Jay, a lot of times people have heard about this term called oncoplastic surgery. Can you help us to kind of wrap our brain around what exactly that is?
And I'd be happy to do that. So let's break it down into two parts. Onco, we think of oncology, cancer, what have you, related to cancer. And then plastic, we think of our plastic surgery colleagues. So this was a term coined in Europe a couple decades ago, which we now in our world of breast cancer surgery use the term all the time. So how do we best think about this? There's two ways of thinking about it. One, in women who are going to save their breast, or what we call breast conservation, there's often an opportunity to reshape the breast or lift the breast or have our ladies look more fabulous after their surgery than they did beforehand. So that's one approach. The second approach is if we need to do a mastectomy or a patient requests it or whatever, one of the things I love talking about is called nipple sparing mastectomy, which again, the scars are hidden, Anise, and that's one of the ideas. We want our ladies, when they stand in front of the mirror after getting out of the shower, look at themselves and say, wow, A, I look great, B, I can hardly tell that anybody ever did anything to me surgically. Does that make sense?
Yeah, totally. And I think that that's such a radical shift from where things were several decades ago when, the diagnosis of breast cancer often meant, not only a mastectomy, but a disfiguring one at that. And so we've seen this shift. Both in terms of an adoption of breast conserving surgery so people can maintain the breast, but even in that, trying to look good and maintain a woman's femininity, their sexuality, their body image, all at the same time. And even for those women who do need a mastectomy, there are so many options with regards to reconstruction so that they really can get back to that normalcy. So I want to take those two in two separate pieces. The first is in terms of breast conserving surgery. Can you talk a little bit, taking even one step back, who's a candidate for breast conserving surgery? And of those people, who's a candidate for this oncoplastic techniques?
Sure, I'd be happy to. First of all, when it comes to breast conserving surgery, probably the best chance a woman has if she's diagnosed with breast cancer of being a candidate for breast conserving surgery is if her cancer was found through screening. We now know that screening saves lives, but typically most cancers found through annual screening are not felt. They're, as we say medically, not palpable. They're often very small and they're a very good candidate for breast conservation. One of the things we're trying to do surgically in oncoplastic breast conservation is to only use 3 incisions, the sort of hidden scar approach. One is around the areola of the breast, so the scar will fade in. A second is way up in the tail or armpit area, so we can dissect down into the breast. Again, when the arm is down, the scar tends to be hidden, or coming in underneath the breast in the fold where the breast meets the chest wall. That's called the inframammary approach. We're trying to do that oncoplastically as a way of hiding scars. Now, anecdotally, I have to tell you, one of my most favorite situations is the woman who's had double D, triple D, large drooping breasts. Their bra straps are cutting into their shoulders. They've got back pain, and a small, tiny cancer is found through breast screening. I have to put a little humor into what I do as a breast surgeon all day long. And if I don't, I'm going to shoot myself at the end of the day. But I'll look at a patient like that and say, wow, do I have a deal for you? I'll bet you've wanted to be perkier, lifted, smaller for many, many years, right? Doctor, how did you know that? Well, I do. So we can combine lifting the breast, reducing the size of the breast, and taking out the cancer and checking the lymph nodes all at the same time. Now that's a real win-win situation and a really good example of an oncoplastic approach. If there's a little bit of drooping of the breast, we can often lift the breast a little bit with our crescent incisions or circumalar incisions or whatever. So it's a case-by-case situation in these, but in general, breast screening translates into a higher incidence of breast conservation.
Yeah, I agree. And I think, Jay, your point is so well taken. So often I'll ask patients, are you happy with the size and shape of your breasts? And, you know, and they often look at me quizzically as to why I'm asking this, but the reason is exactly that. Because just because you have a cancer doesn't mean that you have to stay with the breast size and shape that you have. We have an opportunity to make you even happier. And so if we can do that, why not do it all at the same time? Now, one of the questions that people ask is, well, what about the other side? Can you match the other side at the same time?
Yeah, you can. And the settings that I've worked in, I often work with a plastic surgeon in doing that. We have to be grateful in this country that we have federal legislation that fundamentally says a woman has a right to be equal on both sides. This is particularly true in mastectomy cases. Sometimes our mastectomy, particularly nipple sparing, can end up looking much better than the breast did originally. Well, we're not going to have one looking fabulous and the other looking terrible. And so we can do lifts, we can do other things to make sure that we have symmetry. The key word here for the patient is having symmetry.
Right. And I think that that's another key point that many women really don't know and are often surprised is that symmetry and symmetrizing operations are covered by insurance under federal law, as is reconstruction for mastectomy. So let's move now to that kind of scenario. Sometimes, and this is a question that I get asked a lot as well, patients might have had their cancer diagnosed by screening, but they might still need to have a mastectomy. So for example, I had a patient who contacted me recently who had calcifications throughout their breast and was diagnosed with DCIS. She was told that this was a pre-cancer, a stage 0, not invasive, and yet her doctor said she needed a mastectomy. Can you explain to her and to other viewers out there why that would be the case?
Yeah, good question. Well, first of all, it's when you have large areas of microcalcification like that, and again, depending on the grade of the cancer, particularly high grade DCIS, often the area of the DCIS is actually larger than the area of the microcalcifications. So that's worrisome. Number two, okay, let me stop for a second. The good news with lumpectomy, and if you need radiation therapy, is you get to keep your breast. The bad news is because the breast is still there, you've got a small chance a cancer can recur there. And of course, you need regular screening for that breast. If you've got diffuse microcalcifications throughout the breast, even though much of it or some of it could be from fibrocystic changes of the breast, it's going to be really difficult for a breast radiologist to differentiate the two and to do long-term follow-up. So with extensive microcalcifications like the case you're talking about, doing, as an example, a nipple-sparing mastectomy is a really good option for a patient like that.
Yeah. And so, to your point, not only does it, remove all of the breast tissue, reduce your risk of recurrence, oftentimes it obviates the need for radiation. And you can have reconstruction at the same time. So really, kind of getting back to that size and shape and regaining some of your breast image so that it's not as deforming an operation as it used to be. So in terms of mastectomy, now you've talked a lot about nipple-sparing mastectomy. Tell us a little bit more about that versus skin-sparing mastectomy, when you choose one over the other, pluses and minuses, and all of that.
Sure, I'd be happy to. So there's been a real evolution toward nipple-sparing mastectomy, particularly over the last, let's say, 10 to 15, maybe almost 20 years. So historically, we were afraid to leave the nipple areolar area behind because we thought, A, there might be cancer hidden there. B, we were worried that cancers could recur there. Or C, if somebody came out with a large palpable cancer, actually the nipple areolar area might be already involved by the cancer. So the classic mastectomy that I grew up with is called a skin sparing mastectomy. We're trying to save as much skin as we can, but we're removing the nipple areolar complex. And there are different techniques to hide the scars for that, et cetera, and then do reconstruction. Typically, when we use the term skin sparing mastectomy, we're also implying that we're going to reconstruct the mastectomy site versus total mastectomy, or a term I hate, simple mastectomy, meaning we're not going to do any reconstruction. In that case, we want to try and get the skin down on the chest wall as tight as we can, so it makes it easier for a patient to wear a prosthesis in their bra, subsequently. So there's been this evolution toward nipple sparing, which I'm a big fan of. And we came up with all sorts of early rules for this. Shauna Willey and Scott Spear and the others from Georgetown talk about this a lot. They basically confess we made up some of the early rules about preserving the nipple areolar area. However, with all this experience now over the past 10 to 15 years, we know that nipple sparing mastectomy is extremely safe. The chance that a cancer can reoccur down the road in the nipple areolar area is far less than 1%. It's around 0.6%. Now, there's a caveat here that we've got to share with everybody. Whether you're doing a total mastectomy, a skin-sparing mastectomy, or a nipple-sparing mastectomy, as you well know, no breast surgeon on the planet can say we remove 1,000% of all microscopic breast tissue. We know embryologically the breast tissue can extend from the armpit, the axillary area, all the way down to the upper abdominal wall. So that doesn't mean that patients, even after a mastectomy, should say, well, I'm clear forever, not do any self-exam or anything of that sort. But needless to say, with the nipple sparing mastectomy, we're getting great cosmetic results. However, there's one other caveat when it comes to nipple sparing. Most of the time, we do lose sensation to the nipple areolar area. There are some specific techniques that can be used to try and preserve that, but often, and sometimes the patients are shocked by these and they say, oh my gosh, I look great and it's fabulous, but I have no sensation. We need to be careful and warning patients about that up front.
Yeah, and the nipple really doesn't respond to, sexual stimulus or cold or hot. It really is very much more about cosmesis, but I agree with you that cosmesis is excellent. So let's talk a little bit about the reconstruction part. So whether you do a skin sparing where you preserve the skin envelope, but remove the nipple areolar complex, and there are ways of reconstructing that nipple areolar complex, or whether you do a nipple sparing mastectomy where you preserve that nipple areolar complex and all of the skin, ultimately you still need to replace that breast tissue with something in order for people to maintain their size and shape. So what are people's options there?
Well, we're typically talking implant versus the patient's own tissue or autologous tissue. And this thing has really swung backwards and forwards, particularly with decreasing reimbursement for, let's say, deep flaps or tram flaps, moving the patient's own tissue up. These are hour-long surgeries. They can give outstanding results, absolutely outstanding results. But I don't know about your experience there at Yale, But in most of the settings around the country, I think we're probably talking between 85 to 90% plus is implant reconstruction done in one stage or two stages. The first stage can be an expander, particularly if the patient wants to be a little bit larger in cup size, followed then subsequently by a permanent implant being put in, or what we call one and done, where at the same time if the patient wants to be the same cup size, we can often go direct to implant right at the time of mastectomy. The other big shift that's gone on in reconstruction, historically, we've always put the implant behind the muscle of the chest wall, the pectoralis muscle. Where I've been working at St. Joseph Hospital in Orange, I've been working with a plastic surgery for over 14 years, who actually was one of the earlier pre-pectoral reconstruction people. And that's now a really hot way, if you will, of doing it. And there's less morbidity. We're not disrupting the muscle of the chest wall. We can really get excellent results. And let me ask you this, what's the experience there at Yale? Is it around 85, 90% implant?
Yeah, no, actually it's not. So this is where I think our viewers really need to, get a bunch of opinions and figure out what's best for you. So here at Yale, I would say that the majority actually are deep flaps. Most of our plastic surgeons are trained in microvascular anastomoses. I will agree with you that these are very long operations, often taking several hours to do, requiring you to be in the hospital for several days. And when they do implant reconstructions, I'll agree with you there too, that there's been this shift towards pre-pectoral. But, there are these differences, plus and minus, when you can do one or the other. If you are very, very slim, you may not have enough autologous tissue to create a breast size and shape that is right for you. In terms of implants, Jay, where you're at, given the fact that that's the majority, have you found that many patients are concerned about implant-associated lymphomas?
Yeah, that question came up with the textured implants, and we had patients rushing in and contacting their plastic surgeon and say, oh my gosh, did I have a textured in? Oh yeah, you did 10 years ago, and then swapping them out, whatever. It's so funny when we talk about reconstruction, because you'll have people that are just absolutely opposed to any kind of foreign body in their body, understand that completely. To do what you're doing, you have a highly specialized team. I think people need to know that. To be doing the deep flaps, which is the really go-to flap now, on a large scale basis, you've got to have a highly specialized team.
Yeah.
With lots of experience. There is a small risk of losing, because of vascular issues, losing the flap. But your situation is, I would say, particularly out in the private practice world, is probably not all that common.
No.
But I mean, obviously fabulous that you have such a highly specialized team there at Yale.
Yeah, but that
The
isn't to say
newer,
that implant-based reconstruction isn't good and isn't done. I mean, for a lot of patients, that's really the way to go. And if you are, for example, a smoker, diabetic, and so on and so forth, you may run into problems with the flap.
Yep. Yeah, absolutely. Or the other comorbidities, particularly with other aspects of obesity. I mean, there are all sorts of things that go into it. But one of the things I would say to any patient is, if you want a deep flap, we need to get you in a highly specialized center that does a lot of these procedures.
Yeah.
As far as the implants go, the newer silicone implants, particularly over the last 10 years, are excellent. There doesn't seem to be major problems with them. When it comes to other aspects of reconstruction, particularly with the pre-pectoral implants now, patients are basically, we're almost doing this all on an outpatient basis, particularly with the COVID pandemic, even the one and done. One of the things we do with one and done, where we go straight to implant, we have ICG technology to look at the blood flow within the flaps to make sure that it's adequate. That's been a real safeguard. That's a really important aspect, I think, in any center doing direct to implant, is to have indigo carmine technologies available to make sure the blood flow in the flap is really adequate.
Yeah, and some centers will call that SPY, just in case people have heard of other terminology. But Jay, my last question, to your point about finding expertise. I mean, you were the president of the American Society of Breast Surgeons. There are so many women in this country diagnosed with breast cancer every day. How do they find a surgeon that they can trust? How do they find somebody who has the knowledge and the expertise? How do you figure out where to go when you're given this diagnosis?
Yeah, well, one of the things that you're well aware of, is also a member of the American Society of Breast Surgeons, is the last time I think we did a survey of our membership, probably somewhere in the neighborhood of well over 70% of our members are both general surgeons and breast surgeons, okay? But they're keeping up to date by coming to our courses. They're actively involved in our society, et cetera. Now, for the last 15 years or more, I've been doing breast full time. I believe our society has a list of members based on geographic location. There were a couple of things. If somebody is newly diagnosed, the typical first referral is to somebody like you and I, a general surgeon, okay? Even though you and I are really specialized in breast. The patient should say to the general surgeon, you know, frankly, madam or sir, are you a member of the American Society of Breast Surgeons? Okay, number one, but even more importantly, are you a member of a multidisciplinary team? Because I think, to me, that raises the bar and raises the level tremendously. And thirdly, how does that surgeon, if that surgeon is not a member of our society or not a member of a multidisciplinary team, then do a second opinion, go someplace. All of our academic institutions around the United States have that high level of quality that you have at Yale. We've got them at University of California institutions where I am out west. Seek out that higher level. I have a little book out for patients called the Breast Cancer Answers book. I'm going to do a free plug right now. I'm going to show you my little book called the Breast Cancer Answers book, co-written by myself and a long-term survivor. The reason I brought that up is a key mantra that I have at the beginning of the book is, and I say this really seriously, time is our friend. Because patients come in to see you and I panicked. They're like the deer in the headlights. Doctor, when's my surgery going to be? Tomorrow, the day after tomorrow, early next week? Whoa, time out. We need a lot more information because we have so many more choices. And so we want to take that panic away from patients. You and I both know our patients developed their cancer months and months and months ago, if not a few years ago, from the very first abnormal cells. Let's figure out what's right for that patient. And the best way to do that, of course, is with a multidisciplinary team.
Such good advice. I think that you really do, as everybody who's watching this video, people who have been at my courses, know, you know, breast cancer is a multidisciplinary sport, and you really need to have expertise coming in from all different disciplines. So really, really important. I'm going to leave you Jay's information in the description box below, along with a link to where you can get his book. And a link to his website. I hope that this video has been helpful for all of you. I hope that you will like, share, and subscribe. As always, if there are other topics that you want us to answer, please do leave us a comment in the description box below. We love hearing from you. Until next time, this is Dr. Anise Chagpar wishing you all a safe and healthy week.